Today we will hear from 4 experts in the field. Dr. Abigail Gewurz from the University of Minnesota, director of the ADAPT project as part of the AMBIT network. Dr. Judith Cohen from Allegheny General Hospital, presenting on trauma-focused CBT. Dr. Ellen DeVoe from Boston University School of Social Work, Strong Families, Strong Forces, will be presenting. And finally, Dr. Robin Gerwich from the Center for Child and Family Health, Duke University Medical Center. Before I turn it over to the presenters, I have a few logistic items to address. If you experience technical difficulties at any point, you can send an email to help@nctsn.org. The format of today's presentation does not allow for you to speak directly to our presenters. However, you may ask a question by clicking on a bubble icon in the upper left corner of the screen. Those joining by phone can send an email to question@nctsn.org. We'd like to ask that all of you complete the post-presentation evaluation survey. This information will help us tailor future presentations to our audience and provide useful feedback to our presenters. Anyone wishing to receive continuing education credit for this presentation must complete the post-presentation evaluation survey first, at which time you'll be prompted to complete a post-test. After passing the post-test, you can print your CE certificate. No hard copy certificates will be mailed. Today's presentation will be archived on the NCTSN Learning Center website. This makes it possible to view the presentation later on, as well as complete the CE post-test and print the CE certificate at any time. Okay, now I will turn our presentation off to our first presenter, Dr. Abby Gewurz.
Thank you, Greg. I appreciate it. And I'm really pleased to be able to spend a little bit of time talking with you about ADAPT, After Deployment Adaptive Parenting Tools, a web-enhanced parenting program for military families. And I just want to make one correction to one proviso to what Greg said earlier in his introduction of this webinar. ADAPT actually is not a treatment. It's a preventive intervention for military families where a parent has been deployed to Iraq or Afghanistan in the recent conflicts. So people aren't involved in ADAPT by virtue of having specific symptoms, but by virtue of the risks associated to families of a parent being deployed. If we can go to the next slide, I just want to acknowledge SAMHSA's National Child Traumatic Stress Network, which has funded much of the development of ADAPT, as well as the National Institutes of Health, both the National Institute on Drug Abuse and the National Institute on Child Health and Development, which has funded research to examine the effectiveness of ADAPT, as well as to develop an online version of the program. And we could not do this work without the hundreds and probably by now over 1,000 National Guard and Reserve families who have relentlessly shared their wisdom and kindness with us. And it's really a privilege to work with our military families. We have a fantastic group of facilitators, most of whom are military connected or military personnel themselves. We could go on to the next slide, and I'm not going to spend very much time on the background and rationale, because I assume that if you're listening, you understand why we need to enrich the range of services and supports for military families. I'll just suffice to say with regard to this slide that what we know are 2 important things. The first is that military families are resilient, that being in a military family does not increase risks to children's health and development. What is a risk factor for child behavioral and emotional problems is a parent being deployed to war. And the data that has come out of Operation Iraqi and Enduring Freedom and Operation New Dawn has shown that in a number of ways. But what we're really interested in here is, sorry, let me just say that deployment, there's 2 specific risks associated with deployment when you think about the family. The first is the risk associated with a parent being separated from a child for a very long period of time in a child's life. And that could be multiple deployments of 4 months, for example, in the Air Guard, and a single deployment of up to 22 months, which our Minnesota National Guard families experienced with our 1st Brigade combat team that had the dubious distinction of being having the longest deployment to Iraq. And so that's one reason why deployment is a risk. And the second reason is, of course, what everybody knows, which is that deployed personnel compared to their civilian counterparts, and National Guard and Reserve deployed personnel compared to active duty counterparts are at increased risk for post-traumatic stress symptoms as well as related problems like substance use. If you can go to the next slide. What we're really interested in is understanding how risks to children are mediated through parents' parenting. And there are 50 years of literature showing that when families are under stress, one of the key paths by which children are adversely affected is that parents' parenting suffers. And transitions, another thing that we know is that transitions offer special opportunities for prevention or the promotion of healthy development. And so what we did, if you go to the next slide, is that we tested a theoretical / conceptual model that has actually been shown to be evident in research that suggests that stressful life experiences, stressful family contexts, impair parenting, and that impaired parenting leads to disruptions in child adjustment. And the good news is that if you strengthen and support parenting in the wake of these stressful family experiences, you can also improve child outcomes. And that's what we were testing with ADAPT. And our work is based on Gerald Patterson's social interaction learning model. Patterson is a World War II veteran, found himself on Okinawa at the age of 17, and in actually much later life developed post-traumatic stress symptoms, and has become very, very interested, he's in his late 80s now, in understanding post-traumatic stress symptoms and their impact on parenting. Patterson and his colleagues over the last 40 years have developed the Parent Management Training Oregon model, and that has been shown to be a very effective set of programs for improving parenting and thus improving child adjustment. And PMTO, Parent Management Training Oregon models, in fact, are the largest single group of parent training programs in SAMHSA's NREP, National Registry of Effective Evidence-Based Practices. If you go on to the next slide. So we have this group of parent training programs that have been shown to be effective with a wide range of populations but have never been implemented for military families. And ADAPT was funded to do exactly that, to modify and extend parent training for military families. ADAPT's a 14-week-long web-enhanced group-based program for troops returning from deployment with a school-aged child, a child between the ages of 5 and 12. It's provided in the community by community practitioners, preferably practitioners who are military connected. We are 3/4 of the way through an effectiveness trial to examine the effectiveness of ADAPT among National Guard and Reserve families. So the key adaptations we made to the parent training model include a very strong component on emotion regulation, and those of you who know about post-traumatic stress disorder know that essentially it is a disruption of emotion regulation. And there's no place in which emotion regulation is more important than in the family setting. And there's also no place that it's more at risk. And that effective parenting is really predicated on a parent's ability to regulate their own emotions. And so we spend quite a bit of time teaching parents what we call noticing and observing. You know, others might call it mindfulness exercises. And we also teach parents how to teach their children about emotions, because one of the things we know is that anxiety is extremely high in military families, not just when a parent's deployed, but after that as well. And I would have loved to have shown you some of the web components of ADAPT, but Greg advised me that that wasn't wise on a webinar because of the delay between sound and picture. So I won't be able to show you, but anybody who's interested, feel free to get in touch with me and I can share some of our online components. If you could move forward one slide, the program content covers 6 key parenting skills. Teaching through encouragement, emotion socialization, which is something that we added, which includes emotion regulation and teaching children about emotions and teaching parents how to respond to their children's emotions. Positive involvement, family problem solving, monitoring and supervision of children, and effective contingent discipline. Our groups, as I mentioned, are augmented with the online materials, and those materials consolidate what's been learned in the group sessions. So they demonstrate key skills. Our mindfulness exercises are available in MP3 format for free download from the website. We have home practice and information handouts as well as short quizzes or knowledge checks. And the key way that the content is delivered is through active teaching. It's really crucial. Parents get to role play, practice, practice, and practice again. And a core emphasis is on what we would call United Parenting Front for 2-parent families, really helping them get back on the same page, which is a very big challenge for military parents when one's returned from deployment. I'm going to try and finish in just a couple of minutes because I know that we have 3 other presenters and I don't want to hold anybody up. If you can move to the next slide, I'm just going to briefly tell you a little bit about what we found in terms of the effectiveness of the program. So we have been following 336 National Guard and Reserve families in our study, and each family is followed for 2 years. Families are randomly assigned to either be invited to participate in the ADAPT program, parenting program, or to be offered web and print resources. And parents and teachers complete online questionnaires, and parents, teachers, and children complete questionnaires, participate, and parents and children participate in observational interviews at baseline 6 months, 12 months, and 24 months post-baseline. And what we're interested in is obviously seeing if we can change parenting practices, if we can improve the couple's ability to get along, and of course ultimately child adjustment. And that means reducing behavioral and emotional problems, substance use, improving peer adjustments, and improving parent emotion regulation. If you move on to the next slide, that will give you a brief snapshot of our sample. This is not a high-risk sample. These are families with an average, a mean income in the $70,000 range. They're pretty stable, and we have both deployed fathers and deployed mothers. And if you go on to the next slide, we have so far evaluated the effectiveness of ADAPT with about half our families at post-test, 6 months post-baseline, and a third of our families at 12 months post-baseline. And what we've looked at are the things that you can see on the slide. And what we've done is an intent to treat analysis, which means we compare everybody who did not get invited to participate in the program with everybody who did, regardless of whether they showed up. And about 70% of the families showed up at least once, and most of those showed up at least 7 times. So we were very pleased about that. There were no differences between mums and dads in participation or satisfaction, which quite frankly we were astonished to see and very pleased about. And if you move to the next slide, our preliminary outcomes show that we have significant main effects on improving couple adjustment, improving parents' self-efficacy about their parenting, reducing ineffective discipline, and we actually have significant changes in mothers' observed parenting and in high-risk mothers and high-risk fathers' observed parenting. And another nice addition is that in the high-risk dads, we're also seeing improvements in mindfulness, and that in turn is associated with the main effects that we are seeing in reductions in child behavior problems in the intervention group compared with those who were in the control group. That was a very whistle-stop tour through ADAPT. So if you can go to the next slide, that's my contact information and the ADAPT website. And I would be pleased if anyone is interested or has further questions to answer those at a later time. Thank you.
Thank you so much, and we will make Dr. Gewert's contact information available to everyone at the end of today's presentation as well. Our next presenter is Dr. Judith Cohen, Professor of Psychiatry from Allegheny General Hospital. Dr. Cohen will be talking about trauma-focused CBT therapy for military families. Pleasure to have you, Dr. Cohen.
Thank you. Abby has really beautifully laid the groundwork for what I'm going to talk about also very quickly. So the next slide, please. So trauma-focused CBT is sort of the other end of the spectrum. It's an evidence-based treatment for children who have experienced traumas and for their primary caregivers or parents. It's a structured, time-limited, family-focused treatment, and children or adolescents and their parents or primary caregivers participate. And again, it's time limited, anywhere between 8 and 25 sessions. And the structure is that these are typically parallel individual sessions where in an hour, for example, session, half of the time is with the child, half of the time is with the parent or caregiver, and there are several conjoint sessions as well, as we'll talk about shortly. This model includes resiliency, skill building, and exposure-based components in every session. Next slide, please. So as I mentioned, TFCBT is really appropriate for children who have already experienced at least one traumatic experience. That can be any kind of trauma. Some children have only experienced a single trauma, but many of them have experienced multiple kinds of trauma, including complex trauma. And typically, TFCBT has been most tested for children who have experienced child abuse or domestic violence, but also traumatic grief. And some of these children have experienced military traumas, which we'll talk about shortly. Children should have prominent trauma symptoms because this is really a trauma-focused treatment. But it doesn't have to be post-traumatic stress, and children don't have to have PTSD diagnosis. TFCBT is effective in treating depressive symptoms, anxiety symptoms, and also for reducing behavioral problems if children have those. It can be provided in clinic settings, in school settings, in residential treatment facilities, in-home, in inpatient settings, foster home, or other settings. And as I've mentioned, we really try hard to include parents or caregivers, but we have also shown that if there is no caregiver available to participate in treatment, it can be effectively provided just to children. In military families, that's less of a problem than in other settings, because typically military families want to be included in the treatment. Next slide, please. So what are some potential traumas that military children can experience? As Abby said so clearly, most military children are resilient, but some have more vulnerabilities. As Abby was talking about, prolonged complicated deployment can be a risk factor in and of itself, and as with Minnesota, Pennsylvania is primarily reserve component territory, and we have many families who have had long or repeated deployments. And many of these families have experienced military-related injuries, which can be very difficult or even traumatizing for children. And that can include traumatic brain injury, where parents can act erratically or even lead to violence towards the family. Military mental illness related to deployment, post-traumatic stress disorder, depression, substance abuse, all of the above. Or there have been more than 5,000 military deaths in this conflict, which is not over yet. It's the longest conflict, and this can lead to traumatic grief in the children. And then all of these above circumstances can lead to an increased risk for the more garden variety traumas that we see in civilian children, such as child abuse, domestic violence, accidents, and so forth. So we do see these in military children as well. So any or all of these kinds of trauma experiences can be appropriate for TFCBT. Next slide, please. So just a brief description of TFCBT core elements and principles. TFCBT is a components and phase-based treatment. The phases are provided proportionally, and gradual, not prolonged exposure is integrated into all of the TFCBT components. Next slide, please. So sorry the purple doesn't show up too well in this slide, but on the left-hand side of the slide, you see the TFCBT components going down the left-hand side. These are summarized by the acronym PRACTICE, which is spelled out in the red letters. And the three phases of TFCBT are on the right-hand side. So you can see there are several skills in the yellow letters. So initially we have several components that are building skills initially. That includes psychoeducation about trauma impact. There's a parenting component that goes on throughout treatment. As I said, the parents receive all of these components in parallel sessions. Relaxation skills to reverse the physiologic impact of trauma, affect modulation skills, which is very similar to what Abby was describing, cognitive processing skills to help children and parents address maladaptive, unhelpful, inaccurate thoughts. And after children and parents have learned and practiced and role-played, just as Abby was describing these skills, there's a trauma narrative component or phase where children describe in detail their trauma experiences and process those, make meaning of them. And then an integration and consolidation phase where the child and parent meet together to share the child's trauma narrative, plan for safety, and make plans for going together, for moving together into the future in a healthy and safer way. Next slide, please. So typically, these three phases are provided in equal proportion, so about a third of the treatment is dedicated to the stabilization skills, about a third of the treatment to the trauma narrative, and a third to the integration and consolidation phase. For children who have experienced longer interpersonal complex trauma, there may need to be a longer period for enhancing safety and stabilizing those difficult behaviors and affective modulation. So up to a half of that time might be in the stabilization phase, and then half for the trauma narrative and integration phase. But I do want to emphasize that regardless, this is still a structured, shorter-term model, and it's not years, it's really months. Next slide, please. And again, this is a pictorial description of gradual exposure so that children and parents are increasingly gaining mastery over trauma reminders as each of the practice components is being provided. They're gradually gaining mastery over these reminders so that it's just going up a gradual slope throughout treatment. Next slide, please. So modification for military families. TFCBT has been used in many different trials, as I'll describe in a minute, and there are only a few modifications to standard TFCBT for military families. Of course, we're going to assess for military trauma and response, provide education and resources that are appropriate and specific to those military traumas, and be flexible regarding parent or caregiver inclusion, understanding the timing and accommodation that is necessary for military deployment and permanent change of station and so forth, understand the nature of modern military injuries and the unique needs of reserve component families. And I can certainly go into more detail about that, but not in 15 minutes. Next slide, please. Very briefly, the evidence that TFCBT works. There are now 15 completed randomized controlled trials comparing TFCBT to other conditions, primarily other usual treatments that children receive in community settings. For children ages 3 to 18 years from diverse cultures, settings, and trauma types, primarily for sexual abuse, domestic violence, multiple and complex traumas, but also children exposed to war and sex trafficking, and so pretty serious ongoing traumas. It's been tested in group or individual formats, and also in usual community settings as well as foster care and in international settings. And the mean different kinds of trauma types that these children have experienced has not been trivial. It's been between 3 and 12 different types of trauma. Next slide, please. And compared to different treatments, TFCBT has led to significantly greater improvement in PTSD as well as depression, anxiety, cognitive, and other difficulties, including behavioral outcomes. And also, the final point on that slide is that TFCBT is also effective in improving parental outcomes, and these positive outcomes mediate and predict how children do. So really want to emphasize the importance of including parents in this treatment. Next slide, please. Just a few words about TFCBT implementation and dissemination. We do have virtual training courses, which is important for military providers. TFCBT Web, the address is there, is a free online training course, an introductory training course which provides for 10 free CE credits. Currently, more than 200,000 providers have accessed this course with positive knowledge gain and satisfaction. We also have an additional course for childhood traumatic grief, which provides free demonstrations and printable resources. And that also provides 6 additional free CE credits. And then TFCBT Consult was funded by the NEE Casey Foundation to provide consultation about how to implement TFCBT. And the addresses are here. Next slide, please. So this is just a picture of the TFCBT web homepage. Next slide, the CTG web homepage. And the next slide is TFCBT Consult. Next slide. So our typical training is to provide face-to-face expert training for 2 days, plus 12 consultation calls by an expert trainer, or participating in an approved NCTSN or state learning collaborative with an expert TFCBT trainer. We are also exploring the possibility of web-based, in addition to TFCBT Web, a digitized kind of synchronous training online through the Department of Defense. And so far, in the last 5 years or so, more than 50,000 mental health professionals have completed this, and more than 30 NCTSN or state-sponsored TFCBT learning collaboratives have been completed. Next slide, please. We also have TFCBT Train the Trainer program, TFCBT Train the Supervisor program for supervisors and local agencies, and we're now completing a TFCBT Train the Consultant program to provide consultation for large dissemination projects. Next slide. And finally, we have a TFCBT Therapist Certification program, which is optional. People don't have to do this, but here is the address. It's tfcbt.org. And here are the requirements for therapists to become certified for those who are interested in it. Next slide. I just want to end by acknowledging the federal agencies, SAMHSA, NIMH, and ICHD, who have provided funding for our research, and finally to thank the children and families who have contributed so much to our learning how to help them heal, and to thank all of the military families and my own father, who is a veteran, for helping us to learn so much. And, you know, again, freedom is not free, so thank you for your service.
Thank you for all the information and acknowledgments, Dr. Cohen. Our next presenter today is Dr. Ellen DeVoe. Dr. Ellen DeVoe will be presenting on Strong Families, Strong Forces, responding to the needs of military families with very young children. Thank you so much, Dr. DeVoe.
Thank you so much for having me. I'm really delighted to be here, and I'm so lucky always to go after Abby Goritz and G. Cohen because they provide so much background that I then don't have to cover. But we're here in Boston, and our population is primarily Guard and Reserve, like Abby's. And today I'm going to talk about a little bit about our intervention development and go into our program, in the time that we have. We are concerned with very young children, birth to 5. And next slide, please. we've been funded by the Department of Defense. So we started out about 5 or 6 years ago thinking about the needs of very young children and what was happening in the military. Oh, you know what? Can you go to the next slide, please? Sorry. So our goal was to start out to think about the needs of very young children in military families. We are informed by many of the programs that this community is familiar with and other infant mental health models. Next slide, please. And there wasn't, when we started thinking about this in 2007, 2008, there wasn't much available for kids under 5, and we were concerned about some of the same pieces that Abby and Judy have talked about. How well is the service member doing when he comes home? How well does the at-home parents or caregivers, how well are they doing during the deployment and during reintegration? And certainly the impact of prolonged separation of a parent on very young children. Next slide, please. So we conducted a series of 3 studies over about 4.5 years, and we're very early in our intervention development process in contrast to the earlier models. We wanted to really hear from parents and key stakeholders to learn what the experience of being a military parent is. We're civilians, and we didn't want to assume that we have expertise about their experiences. So we first conducted a series of 70 interviews with service members and at-home parents to learn about parenting, what it was like to be deployed, how do you, thinking about issues like what's it like to parent from a war zone, and certainly talking about reintegration issues. We then put our program together. We have an 8-module program, and we're all home-based. And we conducted an open pilot with 9 families, and we obtained a lot of clinician feedback and feedback from the families about feasibility of the program, the relevance of the content, the helpfulness of the activities that we had tried. And then we modified our program to conduct a randomized clinical trial, which we completed about a year ago. Next slide, please. So in our clinical trial, just a very quick update, we randomized 115 families in total. And I think in the yellow, one of the things we were very surprised about is that we had to turn away about 240 families. And that surprised us. I think it suggests, I think we understand that to mean that families are very interested in talking about their kids and in talking about parenting. The reason that we had to turn them away was because part of our eligibility criteria was that we really were trying to work preventively, so we wanted to work with families who had been home from deployment less than a year. In the treatment arm, we had 57 families, and 93% of them completed all 8 of our modules, and 2 of those families completed 7 out of 8. So we were really pleased with those results. You get a little bit of a sense of our sample. Again, because we're located in New England, we are mostly a Garden Reserve population, so all of our families are living out in the community. We don't have installations that serve Garden Reserve, and so they're pretty isolated from military-specific kinds of services. Our sample also, our families tended to be somewhat older and have pretty good levels of education. Families had about 2.5 deployments, and they'd been back about 4 months. And you don't see on the slide, our families had an average of 2 to 3 kids. In our preliminary outcomes analysis for service members, we see reductions in all kinds of mental health symptoms, parenting stress, and then we also are trying to work at the level of reflective function, which I'll come back to, but we saw some improvements and enhancement in reflective function among parents. Next slide, please. Okay. So I'm just going to go into what our program looks like. So next slide. It should be purple. Okay. So this gives you just the titles of our modules. Again, we have 8 sessions. We chose that number of sessions because we decided that would be, when we heard from families, that was a manageable period of time. It didn't feel like it was, that this program was going to extend forever. It really can be fit into a semester or a summer if you're thinking about the school calendar. And so these are the modules. Our first 4 modules, 1 through 4, we do in order, and we think of those basically as kind of scaffolding. And the last 4 sessions we do, we can move those around depending on the needs and kind of presentation of the family. Okay. Next slide, please. So we are not a skills-based program, although we do a lot of skills work with parents. But we're really trying to work with this construct of reflective function. So I think Abby talked about mindfulness and regulation. So we're really trying to help parents understand what's happening with them related to deployment and related to reintegration, so that they then are able to understand and be curious about and think about what's happening with their baby, their toddler, and their preschooler. And we think that this will result in enhanced and more optimal responses to their kids and just better parenting. Next slide. So this is a slide that we borrowed from Arietta Slade and her work with Minding the Baby. But essentially you can see at the top, and if you think about the context of reintegration and what a service member may be experiencing, that there's a powerful emotion or triggered response, possibly combat stress. And what we really want to help parents do is to recognize that and then be able to work towards regulation so that they're able to attend to their partners and their kids. Okay, next slide. So now I'm going to just run through a little bit about each module so you get a sense of it. In the first module, we're really working on, what you typically do in an early session. We're doing Working Alliance, Child and Family History. The big difference here is that it's very deployment specific. So we're really looking for how has your child kind of grown and developed in the context of prolonged separation and reintegration. How has, military service interacted with your child's, birth and development. Next slide, please. We use a lot of, this has been a really helpful tool. We've used some questions from Charlie Zeno's internal working model of the child interview, and this has been a great ground sort of icebreaker, but it helps us really understand some of the, how well do these parents, how do they think about their kids, and for service members, how well do they know their kids, and, okay, next slide. Okay, in the second module, this is really a military identity module. We call it Becoming a Military Family. And what we found from our earlier work, the needs assessment work with families, that it really was very important to understand the specific military cultural experiences of each family. We know that there's a lot common to military families, but we also know, or we are learning, that there's a lot, that every family has their own way of thinking about being a military family. And so we explore in this module motivations to serve. Why did a service member join? How are they thinking about deployment? Obviously, because we're concerned with birth to 5, we learn a lot and talk a lot about the transition to parenthood in the context of military service and how, becoming a parent may change a person's views and experience of being in the military. And we're also trying to learn the language and the style of communication that the parents have with their kids. So some examples would be, how did you talk to your children about leaving? And so that's a tricky question when you're trying to inform a 2-year-old that you're going to be in Afghanistan for a year. So that's what we're doing in the first couple of sessions. Next slide, please. So in modules 3 and 4, we really we're very targeted in discussing a most recent deployment. As we move out of the wars and away from these conflicts, we're talking about separation more generally. But in module 3, we're working with the parents, and we ask them to consider and kind of talk about and think about their experience of a most recent deployment. And then we ask them to share their experiences with each other and with us as the clinicians. This has been we were very interested in how this module would go, given that we're a new intervention. And we were concerned that about the intensity of this, but we found that parents really have found it very helpful. And that this has been a way, sharing deployment experiences with each other has really opened lines of communication in very early reintegrating families. Next slide, please. So we then ask them in Module 4 to turn their attention to their young child or their young children. So given what your experiences were during the deployment and how you've been affected, tell us what you're thinking about. How do you understand your child's experience of deployment and reintegration? And we get really quite a range. We get parents who are very, very attuned to their children and understand kind of the nuances of babies and toddlerhood. And then there are others who, would like to think that very young children are not affected. They can't remember. And so we call it kind of walking this line of wanting parents to understand the impact, but also not wanting to kind of be doomsayers about the impact of deployment on kids. Okay. Next slide, please. So the last 4 sessions, as I mentioned, we are really focused on the present. So we move from this kind of historical and deployment focus to, okay, so what does all this mean for your life now? How are you reconnecting with your family? How's the family kind of putting itself back together in the context of reintegration? And as you would imagine, some families have more challenges with child behavior. Other couples are struggling more with the couple relationship. So we can really emphasize, the child, the couple, or parenting as families need. But modules 5 and 6, we are called Catching Up with Your Child and Catching Up with Your Partner. In Module 5, we're really just facilitating. We're thinking about everyday family routines and rituals. How can we move dad or mom back into routines and rituals? How can we help the service member literally catch up with what they missed during their deployment? And then similarly, next slide. I'm going to Module 6, next slide. So similarly in Module 6, we are working with catching up with your partner. For single parents, we're helping them to think through self-care. So what does your life look like now as a single parent? And with couples, how can you take care of each other and get your needs met in the context of being a couple? Okay, next slide. In Module 7, I think Abby called this United Parenting Front, which is a great way to think about co-parenting. So in Module 7, we're thinking very specifically about co-parenting as opposed to the couple relationship or the parent-child relationship. So literally, how are parents going to parent together? And in some cases, we do some work around family of origin. So, are there, how was each parent raised? Are there pieces of your upbringing that you would like to bring forward into this family? Are there things that you'd like to toss? So that we're trying to get to help parents be more intentional in the way that they're parenting. And then certainly we're working with behavior management and skills as well. One of the goals, I think, of this module is to help parents anticipate the next separation. So, are there ways that you can think about a plan so that, your the departures and the reintegration, the separation experiences are smoother for everybody. Okay, next slide. And then in the last module, as you would imagine, this is a celebration of a family's completion of the program. We have been talking with families from the beginning that this is a very brief, we're only going to be with your family very briefly. And we've been making referrals, we're talking about hotspots all along. In this module, we're also, I think, like many models, we want to model a good goodbye, a healthy, positive goodbye, since military families often don't have that. Okay, so that's our program in a very quick, I think I have 30 seconds left. But what we're doing now, we've just begun a pilot project with family advocacy in the Air Force, and we are just about to start a collaboration with a site in Fort Hood, Texas, to work with active duty. Okay, I'll stop there. Thanks.
Okay, so that brings it to me. I am delighted to be joining such an incredible panel, and Greg, thanks so much for putting this webinar together. I really do see these programs as truly complementing each other in so many ways. I want to spend the last 15 minutes that we have talking about parent-child interaction therapy, or PCIT, and talk about how we have adapted this for improving relationships in military families. Next slide. As everybody has mentioned, nobody does this work alone, and there are so many people to acknowledge and thank. So I've listed some, and truly the therapists that are implementing it around
the country as well as the families that are allowing us into their lives top my list. Next slide. I think in the very beginning, Abby laid out some really nice information, so I'm not going to repeat much of it. If you go to the next slide, I think the most important piece from this slide is looking at just the fact that there are so many parents, which is very different than in wars past, and that the children are very, very young. Families are young families. Next slide. If you look at how many, when we're talking about young, we're talking about under 7. So over half of the children are under 7. And the sweet spot for PCIT, PCIT was really developed for children between the ages of 2 and 7, and so that sweet spot of 3 to 5 hits almost 50% of children that have been impacted by deployment. Next slide. So if we summarize some of the challenges facing young children and their parents, reports of behavior problems at home and in the preschool setting. It's already been mentioned some issues around increased risk for depression and anxiety, and some of the new findings coming out on marital dissatisfaction. It's very interesting. Although there's an increase in marital dissatisfaction, there is not an increase in intent to divorce. So they stay together, but they may not be so happy about it. Some increased sense of social isolation, increased risk of child maltreatment, particularly during the service member's deployment. Most importantly for our work, some increased stress in the parent-child relationship. And then what we know is that we're seeing so many more service members coming back with increased rates of PTSD, which seems to also be associated with similar reactions in family members, and then an increase in TBI. So next slide. So the bottom line is we have to figure out how do we help. And as we were starting to look at this, we started trying to think about what would be a good fit for trying to help and change the trajectory, to change the outcome. So if we go to the next slide. If you look at the findings that I just mentioned, the main issues with our military families, and then look on the other column of what are the goals for PCIT, and as I was starting to think about this, I thought, wow, so many of these things map on so beautifully from the civilian literature of what we know from years and years of PCIT research. Better behavior problems, better parenting skills, generalization to multiple settings, reduction in child abuse, recidivism, reduction in trauma symptoms, improved benefits for the parent and the caregiver, decreased parenting stress, decreased depression, so and success with parents with cognitive deficits. So as we started looking, it made sense to us that we began to think about PCIT with our military families. So if we go to the next slide. You know, I was struck with when Abby was talking about where ADAPT came from and Patterson's work. It always makes me smile because I think what an incredible cohort of individuals were all together in Oregon. And so you had Patterson's work with PMTO. You have Sheila Iberg creating PCIT. You had Rex Forehand creating the non-compliant child. So as I talk about PCIT, you'll say, well, that sounds really similar to what Abby's doing, and I think it is. They all sort of come from the same mothership, so to speak. But, excuse me, PCIT is not prevention, so it would be sort of the next step down the continuum from both Abby's program and Ellen's program for families that needed treatment. So PCIT is truly a treatment that was developed by Dr. Iberg in the late 70s primarily for children with disruptive behavior disorders. Very strong evidence-based treatment with numerous RCTs, and like TFCBT, it's relatively short-term, 12 to 15 weeks, but we're finding around 15 to 20 weeks when we move it out to the community setting. One of the things that makes PCIT very unique, it is in vivo direct coaching of the parent and the child together. So it's a strengths-based model. Together, the therapist and the parent form a team, and building on the strengths of the parent, teaching them new skills, giving them confidence and responsibility to move forward to enhancing the relationship. Because as everybody has already talked about, we really do believe that it's through that parent-child relationship that we're going to see the biggest changes for all family members. Next slide. If we think about the key features of PCIT, again, as an evidence-based treatment, it is manualized. It is very much assessment-driven, and so parents are working to meet certain markers each week. It's very transparent, and so parents are giving feedback on how well they're doing. There is a coding system that's used to give them feedback on how their relationship, how they're mastering skills that are being taught, and what impact that's having on the child. So if you go to the next slide, in terms of what does PCIT involve, there's generally two phases of there is always two phases of treatment. The first phase is the child-directed interaction, and the second phase is the parent-directed interaction, which I'll talk about in a second. Parents come in for a teaching session, one per phase, and then it's usually about 3 to 5 coaching sessions for families to meet mastery. There is homework involved, but homework is a relative term. We ask families if they can devote 5 minutes of practicing their skills at home with their child, and then when they're with us, we will coach them directly with their child to meet the mastery, and then there's generalization and graduation. So if we go to the next slide, on this slide you see the goals for the first phase of treatment, and they're pretty big. To say, gosh, we're going to start this, and we want to see changes in about 3 to 5 weeks. But what we do see is changes exactly in all of these areas within about 3 to 5 weeks. Does that mean that they're finished? No, that's the beginning. But parents are continually reporting changes pretty quickly as treatment gets started. Once they meet mastery, they go to the parent-directed interaction. So if you go to the next slide. So in parent direction, we continue to work on those goals from the first phase of treatment. Those continue. They're the foundation, and we coach them to continue and improve and strengthen those skills throughout the parent direction interaction. But in the PDI, we're really working on some contingency management. We're working on problem-solving discipline, how to create an effective positive discipline program, and a very structured and consistent and predictable program. So then we decided, okay, how do we take this and apply it to military settings? So if you go to the next slide, honestly, for us, there was a little bit of a learning curve as we started having to learn new language and new ideas. I always joke I've made the mistake one time of calling a Marine a soldier. I will never ever make that mistake again, but it really is a new culture, and we have to be mindful. I've certainly learned that along the way, and feel so appreciative of all of our service members that have shared their insights with us as we've moved forward. So if you go to the next slide, I think the biggest shift that we found first as we started working with military therapists was shift to the idea that you're going to see the child and the family together every session, but the teaching involves the child and the family being actively seen for the entire session together. And then talking about working with a very young child, not always something that people have had experience with. Some reframing the issues, talking about stress and deployments, and focusing on the strengths that are bringing in both the family, that all members of the family are bringing in. So if you go to the next slide, some of the adaptations that we made have been a presentation on military culture and deployment stresses for our therapists, just to make sure that they're all talking from the same page when we talk about doing this with very young children. We work on engagement strategies specific to the military. We have actually revised and made new training videotapes and examples and role plays for teaching therapists how to use PCIT with military families that are all specifically and military themed. And so if you go to the next slide, we're looking for the same results in civilian populations, from civilian populations into the military populations. We've just started. We have, if you go to the next slide, we've got some very, very, very early pilot data just on a small sample of about 11 families. But they are reporting positive changes in child behaviors, reduction in some trauma symptoms, huge changes in marital satisfaction and parenting agreements, and significant changes in parenting stress. Let's go to the next slide. As we're moving forward, what we're hoping for is to not only continue to gather on a more large-scale information that is similar to some of the outcome data that we see in our civilian PCIT studies, but we also want to look at what impact does PCIT have on families that are coping with TBI and PTSD. We think they could moderate. So where a child with behavior problems may be, some of the screaming and yelling may trigger a service member, is that's reduced and there's more positive relationships in the home. Does that complement the work that he's trying or she's trying to do in PTSD treatment? Because it works so well with parents with cognitive deficits, we do believe that we can give families that are coping with TBI some new strengths to allow them to feel confident in their parenting and to be a help. And then as we see increases in child abuse, we do think that there may be similar reductions in recidivism with reports to the FAP. So I've got about 1 minute left. So if you move to the next slide, the bottom line is our therapists are enjoying this. Our families are liking this. If you go to the very next slide, families have repeatedly said, gosh, homework, coming in, having the structure works very well because I'm in the military and orders are taken well. So that's a big plus. And the next slide, I think as everybody's talked about, we really see resilience in our military families, and how do we help promote that? How do we help underscore that for families that may be really struggling? In my last 30 seconds, PCIT, we're trying to move it out. What we'd really like to see is if I am at base A and I PCS to base B, that I don't have to start all over again in treatment, that I may be able to move to base B and pick up exactly where I left off or pretty close to that with the next PCIT therapist, because sessions are, because the treatment is a manualized treatment. Training is intensive, I guess, but it takes, it's about 40 to 56 hours of training, depending on where you're getting it, but a minimum of 40 hours of training with by twice a month follow-up consultation calls for a year until you finish at least 2 cases. And then videotape reviews, reporting fidelity, information reporting skill summaries so that we can assess how families are moving through. But we have several therapists. The feedback is good. We're trying to move it out. And the last slide is simply, if you want more information about PCIT in general, you can find that at pcit.org, and I think, Greg, you're sending out our contact information. If you have any questions at all about PCIT for military families, please don't hesitate to drop me an email, and I'll get back to you as soon as possible. And I will stop. Thank you very much.
Thank you so much to all of our speakers for sharing your experiences and insights today on services prevention and treatment for our military families.